Let's talk about leukemia lymphoma. Leukemia, that's a lymphoid or myeloid neoplasm with widespread involvement of bone marrow. Tumor cells are usually found in the peripheral blood. In the blood. Lymphoma mass, discrete tumor mass arising from lymph node. A variable clinical presentation arising in atypical sites, leukemic presentation. Now we have Hodgkin versus non-Hodgkin lymphoma, meaning mass. Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma, well, both of them have constitutional B symptoms, which is low-grade fever, night sweats, weight loss. Low-grade fever, night sweats, and weight loss. Hodgkin lymphoma is a localized single group of nodes with contagious spread. Stage is strongest predictor of prognosis. Better prognosis. It is characterized by Reed-Sternberg cells. Looking at this picture, you can see the Reed-Sternberg cell, but we will come back to it. Let's just finish this. It's a bimodal distribution. Either you're young or you're old, greater than 55. Associated with Epstein-Barr virus. On the other hand, non-Hodgkin, let me change color for non-Hodgkin, that is multiple. See, this was single group of lymph nodes. This is multiple lymph nodes. Extranodal involvement is common. Well, that was uncommon. Non-contagious spread. That shows multiple lymph nodes. And it is worse prognosis. Majority involves B cells, rarely T cell lineage. Can occur in children and adults. May be associated with autoimmune diseases and viral infections like HIV, EBV, and HTLV. So let's talk about now Hodgkin's lymphoma. They contain Reed-Sternberg cells. Which are the distinctive tumor giant cells, bilobe nucleus, with the two halves as a mirror image, like in all eyes. Looking at a picture there. Reed-Sternberg cells are CD15 positive and CD30 B cell origin. 2 all eyes times 15 is 30. So these RS cells, they have CD15 positive, but also they are CD30 positive because they're coming from the B cells. You have the subtypes. What are the subtypes? You have nodular sclerosis. This is the most common. You have the lymphoid rich, mixed cellularity, lymphoid depleted. Okay. So in mixed cellularity, it is associated with that those are Reed-Sternberg cells. They are producing interleukin 5 that stimulates eosinophils, leading to eosinophilia. So here, eosinophilia in mixed cellularity because of IL-5. And for lymphocyte rich, because they're rich, so it's best prognosis. Well depleted, I mean worse prognosis. They got no money in the bank. Seen in immunocompromised patients. Okay, so that's for the Hodgkin lymphoma. Moving on to non-Hodgkin lymphoma, what do we have? We are looking at neoplasms of mature B cells and also the neoplasms of mature T cells. So in the neoplasm of mature B cells, we have Burkitt lymphoma. Burkitt lymphoma occurs in adolescents or young adults. Burkitt, kid for kids. Very important. What do we have for the genetics? What the translocation is 8 and 14. 8 to 14 translocation of c-MYC gene on chromosome 8 and heavy chain of IgG on chromosome 14. Okay, so you will have, very importantly, starry sky appearance. Sheets of lymphocytes with interspersed tingible body macrophages. Arizona associated with EBV. Jaw lesions, very important. In endemic form in Africa. Pelvic or abdomen in sporadic form. So let's look at A and B picture. A, we have the sheets of cells, sheets of lymphocyte with interspersed tingible body macrophages. So we have sheets of lymphocytes with tingible spread across tingible body macrophages with sheets of cells with sheets of starry sky appearance. Okay, and the other picture is jaw lesion in the Burkitt lymphoma. Okay, that's all about the Burkitt lymphoma. Second thing we have, that's the diffuse large B cell lymphoma. It's in older adults or 20% in children. Mutation is BCL2 and BCL6. Most common type of non-Hodgkin lymphoma in adults. So how they're going to present? Well, they're going to present with a rapidly enlarging nodal or extranodal mass, either some lymph node or extranodal mass. Okay, and then you have the follicular lymphoma. Follicular lymphoma are seen in adults. Translocation 14 to 18 translocation. Translocation of heavy chain IgG, which was on 14, and BCL2 and 18. Now, indolent course. What does that mean? That means it's a slow progression. Painless waxing and waning, lymphadenopathy. Waxing when it comes and goes. There's coming of lymphadenopathy and then it going of lymphadenopathy. BCL2 normally inhibits apoptosis, so when you have increase in BCL2, normally it is inhibiting apoptosis normally, then you cannot inhibit apoptosis, leading to formation of lymphoma. Then you have this mantle cell lymphoma. Mantle adults, males, they are mantle, greater than the females. Translocation is 11 to 14, in which of the translocation of cyclin D1 and heavy chain IgGs and CD5 positive cells. This is very aggressive. Patient typically present with later stage disease. Then you have the marginal zone lymphoma. Seen in adults, translocation is 11 to 18, associated with chronic inflammation, example Sjogren's syndrome, chronic gastritis, maltoma, and may regress with H. pylori eradication. Okay, I think we did talk about this in GI lectures. The formation of maltoma and how it forms the marginal zone and maltoma, marginal zone lymphoma. Okay. Then you have the primary central nervous system lymphoma. This is the primary CNS lymphoma. Primary means primary. It's seen with EBV associated with HIV and AIDS, considered an AIDS-defining illness, even like immunocompromised state. A variable presentation like confusion, memory loss, seizures, CNS mass. Often single ring-enhancing lesion on MRI, immunocompromised patient. Looking at this picture C, you have a ring-enhancing lesion, a CNS mass, right? Single ring-enhancing lesion on an MRI. Needs to be distinguished from toxoplasmosis via CSF analysis or the lab tests. So do some labs to differentiate between toxoplasmosis, otherwise they look similar on MRI. So then we have the neoplastic of mature T cells. Well, T cells in adult T cell lymphoma in adults, it is caused by a HTLV, which is human T cell virus, associated with IV drug use. Adults present with cutaneous lesions, common in Japan. T cell in Tokyo, that's a good mnemonic. T cell in Tokyo, West Africa and Caribbean. Lytic bone lesions and hypercalcemia is seen. Mycosis fungoides or Sézary syndrome, seen in adults. Mycosis fungoides are skin patches and papules. Looking at this, you have the skin patches and papules. Cutaneous T cell lymphoma. This is cutaneous skin T cell lymphoma, characterized by atypical CD4 positive cells with cerebriform nuclei and intraepidermal neoplastic cell aggregates. Posterior microabscesses may progress to Sézary syndrome, which is T cell leukemia. Okay. That's pretty much what we have for the non-Hodgkin lymphoma.